Spinal meninges. These are broadly similar to the meningeal layers that you find around the brain, inside the cranium, but they're easier. So that's good. I'm sure that's quite a relief. And we're going to also include spaces between dural layers as appropriate. Epidural space around the spinal cord it's real. And by that I mean it does exist even when you don't have like some sort of pathology like a ruptured blood vessel. It's not a potential space. It is quite real. And in this diagram here from your book, you can see all this yellow stuff right there. That is fatty. It's adipose tissue that fills in the epidural space. So it's padded with adipose, but it is in fact a space. And we'll talk about it in a minute, but that is a space that, well, actually we can talk about it now, I guess. That is the space in which you would put anesthetics. We're going to talk about another clinical issue here in a bit. Not that particular one, but yeah, epidural space is where you would want to put something to deaden the nerves, but not actually get into the area with the spinal cord. So the next layer deeper would be dura. And dura around the spinal cord is only a single layer. There are no infoldings of dural septa. There are no sinuses, nothing. It's quite simply a single layer of dense irregular connective tissue, very tough tissue. It fuses with epineurium. So hopefully that word sounds familiar, at least familiar. When we, in chapter 14, looked at the structure of a nerve in cross-section, the nerve has connective tissue layers around it, just like muscle had connective tissue layers around it. And you have the entire nerve covered in a connective tissue layer called epineurium. That's that. And then we'd have fascicles that are surrounded by perineurium. And then inside, each little axon has endoneurium around it. So what you should know in this moment is that the dura mater actually fuses right, oh, well, you can kind of see it there. Here we go. The gray is supposed to be the dura mater. The dura mater fuses directly with that epineurium that surrounds the entire nerve that is eventually going out to somewhere in your body. So, same tissue, makes sense. Subdural. Subdural is below the dura, deep to the dura. It is a potential space. It normally does not exist. The next layer down, just like in the brain, the arachnoid mater. It is that spidery layer that is, well, they've represented it here. The spider web there. Can't really see it in there, but I assure you it is. It is there. And it is superficial to, of course, the subarachnoid space that would be deep to it. Subarachnoid space is a real space, and it's filled with something. Same as in the brain, we have CSF. Cerebral spinal fluid is in the subarachnoid space around the spinal cord as well. And it's coming from the same place, it's same circulation, so we don't have to redo the CSF circulation. And finally, pia. Pia would be the deepest layer. And actually, we have a little bit more to do with pia in the spinal cord than we did in the brain. In the brain, I just said, well, it adheres really tightly. It's this thin layer of areolar tissue, and it follows every fold and groove around the brain. That is not entirely true in the spinal cord. So in the spinal cord, it does follow every sulcus and fissure, and et cetera, around the spinal cord. But at the very, very tip, the conus medullaris here, there is a thin strand of pia that comes away from or comes off of the spinal cord and then eventually anchors. So if you can imagine, there's a thin layer of pia that surrounds the entire spinal cord, and then the cord ends, but this, little strand of areolar tissue goes all the way down to the very, very end of the the vertebral column. And it actually anchors the spinal cord and keeps it from, well, bad things happen. It's called an untethered spinal cord, and I guess it can curl back up, and there it's not good. So the filum terminale is really the only place where you can see in the body one other place, but there's one of the few places where you can see pia mater by itself. If you were in lab and you saw a full spinal cord, yeah, that's almost better. No, it's not. They're both terrible. Okay, so instead of doing it here because it's just terrible, let's just draw over here. So this, if you can imagine, is the conus medullaris, the very distal end, or shouldn't say, inferior end of the spinal cord. And then you remember we have all these nerves coming off of it. And they're heading out. Sorry, I don't have them coming out at really good levels, but you remember they'd all be hanging down here, and you've got this big bundle of spaghetti strands. It's called the cauda equina. Now, we'll add some pia. So pia would be surrounding the entire spinal cord, right? Well, technically, it would just be a layer around the entire spinal cord. And then coming off the very, very, very tip of the conus medullaris is this thin strand of pia. And it's going to run in the cauda equina. Now, if you were in lab, you would be able to see this really nicely, and you wouldn't be able to tell very well the difference between pia and a nerve. So I found that pia tends to be a little bit darker, but that alone isn't going to tell you whether or not it's pia. What you have to do is really dig around until you find the conus medullaris, which if you were in lab, you could find. Maybe they've had video. Sorry, the puppy's going nuts behind me. Anyway, you look for whatever strand was coming off the very, 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 very tip, and it does come down to like a point, just like I've drawn it here. And then anything else that's coming off even a little bit higher than that point, that is a nerve. The thing coming off the very point is the filum terminale. Okay, the other place, I kind of left it out. Well, I'm going to use this one. The other place, I'm going to bounce forward and just show you the other thing I'm going to show you, how to spell it. Denticulate ligaments. Those are also pia. So I'm going to draw the spinal cord a little bit longer now. I'm not going to draw all these nerves coming off. Well, I'll draw a couple. There you go. There's some nerves, and as you go up the cord, they're going to come out more, sideways and not drift down as much. I'm doing a terrible job, but here we go. This is what I want you to see. It's totally covered in pia, but in between the nerves, we get this little bit of pia that kind of just pulls away, and it actually anchors to the lateral sides of the vertebral column. And this is like, anchoring the column side to side, whereas the filum terminale is anchoring it, I guess, top to bottom. And so these little things that, I drew them like triangles, they kind of look like that, though. I've exaggerated the size, but they do look like they pulled away and just pinpoint right there. Those are your denticulate ligaments, also made of pia mater. So more interesting features in pia than any other in the spinal cord. All right, this is the clinical thing I want to get to, not an epidural injection, but a lumbar puncture, also called a spinal tap. So what is it that we want? What is our objective? Our objective, piercing there, is to get, we'll look at that in a minute. And you know what? I'm not sure if that's the page number in the 6th edition. Look for that image that'll pop up again here in a minute for a description in the textbook. Anyway, your objective in a lumbar puncture is to get some CSF. You want to get some of them out of there. Be any number of reasons. Maybe you think there's an infection. Could be too much pressure in there. Who knows? You want to get some CSF sample, though. So what structures would you pass through in order to get a sampling of CSF? And the first question is actually, where on the vertebral column would you do this? What region? Well, the best place is going to be lumbar region. In fact, we could go all the way. So inferior to the conus medullaris. Oh, the conus medullaris is actually right there in this drawing. Sorry, this thing's so terrible, I can't see a thing. So there's the conus medullaris. You want to be inferior to that because if you think about it, so say you have spaghetti, it's all parallel strands of spaghetti, but nonetheless spaghetti versus like a hunk of sausage. It would be less likely that you're actually going to stab a spaghetti with that ice pick than if you were trying to go for the sausage. The sausage is probably going to get stabbed, so you don't want to stab the spinal cord. No. But when you stick a needle into these nerves here in the cauda equina, it's much more likely those nerves are going to just, push aside and you'll be okay. But I've talked to people that they can nick one just with the needle, just a little bit, nick a nerve. Very painful. But not very likely to do any serious damage, any serious permanent damage. Okay, so we've concluded that we're in lumbar level in the cauda equina. What are you going to pass through? Well, most people forget all this stuff. Well, you're going to pass through skin and subcutaneous, right? Muscle. You actually wouldn't know what muscle that is because we didn't cover that particular one. No, nor did we cover these ligaments. you're going to go somewhere between two. These would be a spinous processes. So just to orient a little bit, should have done that. This is lateral view. So we're looking for the side. This would be the posterior. And so, of course, you'd be coming in from the posterior on the patient. Those are vertebral bodies in the anterior. And you're going to pierce through some ligaments that you don't know. Don't worry about it. And then what's going to be that fatty space? So, or it's fatty, that adipose tissue, what space is it in? That would be the epidural space. And then next layer down, you should just be thinking from superficial to deep. You're going to hit dura, arachnoid, and then don't forget the subarachnoid space. That is where you're going to stop. Most students go all the way to pia. I'm like, no. I mean, I guess you could hit the filum terminale in here because it's somewhere. The filum terminale is right about there. Well, somewhere in there. But yeah, you would have no necessary reason to get to pia. You stop in the subarachnoid. That's where your CSF is. And then start to pull it out with your syringe.